Good afternoon, everybody. Welcome to Cancer Support Community Central Ohio's Lunch and Learn session. We are so excited to have Dr. Dibs here today presenting on radiation therapy. Thank you, Dr. Dibs, for sharing your time and your expertise with us.
Yeah. Hey, good afternoon, everyone. Thank you so much for inviting me to be here today. It's truly an honor to speak with you. Before I begin, I would like to recognize something important for every person here listening. I've been touched by cancer. Some of you are patients, some are survivors, others are caregivers, spouses, and children, parents, or friends. Each of you has your own story, and each story is unique for sure. So, as a physician myself, I spend a lot of great deal of time discussing scans, treatments, test results. But behind every scan is a person with hopes, fears, questions, and dreams. So that's why we're here. And also, the cancer community is supporting you guys. But today, I'm just going to go over a couple things about the radiation, which is part of treating of cancer. We're going to talk about the radiation therapy and what is it is recommended, the treatment, what it looks like actually, and the side effects to expect. And then hopefully we can replace some sort of some fear with understanding what's going on. And then before also we begin dive into this subject, I like to share one of my favorite quotes here. Is knowledge does not eliminate uncertainty, but it replaces fear with confidence. So that's why education is important about specifically here. I'm going to talk about the radiation. But going back in time, how we discovered radiation is the story of radiation therapy began with curiosity back in 1895 with Röntgen discovered invisible rays that can pass through the body and create a first X-ray image. And just a few years later, Mary Curie, she's worked on radioactivity and revealed that certain materials naturally release energy. And scientists really later realized that this radiation could affect cells and perhaps it could be used to destroy cancer cells. And more than a century later, that idea has evolved into today's highly precise radiation, where we can target tumors with remarkable accuracy while protecting the healthy tissues around them. And then just to focus on Ohio, the incidence of cancer here, it's kind of about 460 per 100,000 in nationwide, but here we're about 484 per 100,000. That, like to give more numbers here, the more than 80,000 Ohioans are diagnosed with cancer each year, and more than 25,000 Ohioans die from cancer annually, make it the second leading cause of death in the state. And we're just highlighting the most common diagnosed cancers in Ohio, such as breast, prostate, lung, colorectal, and melanoma. Personally, I'm more focused on treating cancer of the central nervous system and also the head and neck. But if at some point someone needed help with anything that I can guide you guys to where to go for the patients or the survivors or whatever the questions you need, I'm happy to share my email. So for you guys to reach out to me or through the community, the Cancer Community Center. And so cancer can be treated with different methods. Can be treated with surgery and with systemic therapy. We have chemotherapy, we have immune therapy, we have targeted therapy, and we have the radiation that it's been here for about like since the 1950s, or a combination of these. So when people hear the word radiation, they often become nervous, which is normal. Many imagine something dangerous or mysterious. Uh, but radiation therapy is actually one of the oldest and most successful cancer treatments we have. More than half of people diagnosed with cancer will receive radiation therapy at some point during their treatment. And the radiation works by damaging the DNA inside cancer cells. And cancer cells are unlike healthy cells. Cancer cells are much less able to repair the damage from the radiation. And over time, those damaged cancer cells stop growing and eventually die. Meanwhile, the healthy surrounding tissues are much better at repairing themselves. That is why modern radiation is carefully designed to maximize damage to cancer cells while minimizing damage to normal tissue. And the common question is radiation therapy like having an X-ray? Is typically this kind of radiation as if when someone goes under the CAT scan, we get radiation, but this radiation is stronger and it's focused to where we're gonna treat. So typically the answer is yes, most of the time, and the machine looks similar to the CT scan, but the treatment itself is painless. So you can't feel the X-ray, and then you cannot see the radiation, you cannot smell it or feel it. Nothing touches your body. It's like the machine is farther from you. So there are no sparks or burning sensation or electrical shocks that you're gonna get, but most patients are surprised by how simple the treatment itself feels. The difficult part is not the treatment, but the challenge is usually the side effects that gradually develop over several weeks after the radiation. Usually we give the radiation, we have different kind of radiation that I'm gonna go over, but typically we give the radiation over weeks, just trying to split the doses over days so we can have less side effects. But at the end, we have cumulative dose in the body that will lead to side effects that sometimes they might last longer, but other time they might go away after finishing radiation gradually. But we do things during radiation to mitigate the side effects, especially for the skin. We give creams. For the mouth, we do taking care of the hygiene. Other sites, like in the bowel, near to the bowel, we give some medications to mitigate the side effects on each area. So why we do the radiation? We do the radiation typically to cure the cancer. And we use radiation sometimes only, like to do only radiation for prostate cancer. We can do only radiation for head and neck cancer, some early lung cancer as well, cervical cancer. And many patients are cured. And the earlier we know about the cancer, the better the outcome. But typically, we can cure radiation with radiation only, but sometimes we have to give chemo along that or some sort of systemic therapy or surgery. Other option, like why we do the radiation, is to reduce the chance of having the tumor coming back for sure. And also we have to relieve the pain or symptoms. Some patients will have like big tumor that leading to pain, bleeding, difficulty swallowing, or any symptoms in the brain, any symptoms on the spine, breathing problem. And that radiation can help mitigate these symptoms along with some sort of other medications. And one of the most rewarding part of my job is seeing patients feel better after the radiation for sure. And recently, you might hear about the radiation be given to benign diseases such as osteoarthritis, plantar fasciitis, vascular abnormalities in the brain, mainly, and trigeminal neuralgia and others. So those you might patients or people, they may see that on the internet. So don't hesitate to reach out to your PCP or the primary care physician, or even like reach out to the radiation oncology department here, or reach out to me if there's any chance that we can help you, we can direct you where to go. And then one of the most common questions that I hear from patients is, will I become radioactive? So the answer is no. So you're not going to be radioactive. You can hug your spouse. You can be around your grandchildren. You can sleep next to your partner, be around pets, go to work if you feel well enough. So there's no radiation left in your body after we give you external beam radiotherapy. But there is an exception here, is that certain internal radiation, right, and like brachytherapies, we call internal radiation, and radioactive iodine are like, we give some special precautions may be needed at some time. So, so that the only exception here, but generally the external beam radiotherapy, you will not be a radioactive. Here I just putting some two pictures here, but patients are often surprised that the planning takes longer. So it might take about 2 weeks to be ready because there's a lot of things going behind the scene. A consultation with a radiologist, we review your diagnosis, discuss the options, review imaging, and we answer questions. And next, we do like some sort of something called a CT simulation. The CT simulation is this look like a normal CT scan, like a regular CT scan. That's where we map where we're gonna treat. And then we wait for about 2 weeks to create your personalized treatment. And we call you back here on the machine and we saw the radiation, and then we give you the details of the radiation, how we're gonna give it. And then to make things more precise is that we use certain things to make you stay still. So on the left side here of the slide, you can see the mask. And this mask, we make it for the patients who are going to get radiation above the clavicle, like above the collar here, just to make sure that you're staying still during treatment, because this radiation is very pinpointed. So after that, we have a team of experts, including medical physicists, dosimetrists, radiation therapists, nurses, and physicians. We work together to create an individualized treatment plan. And sometimes this planning takes several days. That is because every treatment plan is personalized. There's no two patients exactly alike. So this is the one that how it looks like, the machine on the left side, and on the right side, how the radiation travels from different angles to pinpoint the radiation to the area of interest. So most treatments last about 10 to 20 minutes. I would say like maybe about most of the time, the whole visit, each treatment is about 30 minutes to 45 minutes. So the actual radiation is delivered for a few minutes, but there's a lot of logistics behind the scene that we're making sure that you're aligned well under the machine. And then we turn on the radiation, which takes a few minutes each time. And the machine will rotate around you, does not touch you. The therapist will leave the room and you'll be by yourself, but we have cameras, speakers, and mics so we can hear each other during the procedure. And then, and if you need anything, the treatment can be stopped immediately for sure. I use an analogy like how we pinpoint the radiation is that back when we were younger, we use this the convex lens, the sun and magnifying glass experiment, where we bring the radiation from the sun and we pinpoint it to the paper to kind of like burn the paper. It's like the same idea. We're not burning inside, but it's just like an interaction between like an energy between the photon and where the tumor is. So yeah, I just remember I was chat about this example. The radiation therapy has been evolving significantly, especially over the last 20 years. We have the modern radiation, which is technology, allows us to shape radiation around tumors with remarkable precision. And we have the image-guided radiotherapy, where we guide where we're going to radiate based on the image. And we have the intensity-modulated radiation therapy, where we map on the tumor from different angle of radiation, just to pinpoint the radiation to the area of interest and lower the doses in the surrounding structures. You might hear of something called stereotactic radiosurgery or stereotactic body radiotherapy, which is another form of high dose of radiation that is very conformal, pinpointed to the area of interest, to have like a better outcome while minimizing the side effects. There's a proton therapy, which you might heard about more frequently recently, is a particle therapy that travels through the skin and deposit the dose at certain area, and there is no scatter radiation after that. So for this will lead to decrease the chances of having side effects beyond the area where we're gonna treat. So these technologies allow us to better protect healthy organs while effectively treating cancer. So what side effects should the patient expect?
I'm sorry, may I ask a question before you get into that?
Yeah, sure.
For my prostate cancer, I had to have gold markers put in so that they could make the alignment before each radiation session. Is there such a thing for other parts of the body where other organs are involved? How do you basically target and make sure that, you know, the organ doesn't move or somebody doesn't move if they're not using markers like that?
Yeah, we use different kind of, that's a great question, actually. So yeah, for the prostate, we use the markers. We place 3 different markers in the different areas of the prostate. It's like, you know, to know the spatially where this prostate is. And we do a CT scan, which is a cone beam CT scan, where we know where we're gonna treat, and then we turn on the radiation, just making sure that the radiation is pinpointed to the prostate. And that fiducials, or the gold markers, they are like followed while the radiation going. It's like lively. We see where the radiation is going. From other sites of like different kind of, we can use those gold markers in other sites of the body, like in, for instance, like liver and esophagus, pancreas, different kind of areas. But also we use the cone beam CT scan, which is a CT scan, like a regular CT scan, but it's like lower energy, just to making sure that we see where is the tumor and the anatomy. Mainly, we see the bony anatomy and the surrounding anatomy, just to make sure that the planning mapping CAT scan is aligning well with the reality of where the tumor is. So the cone beam CT scan, we use it. There's a skin. We follow like the skin, like the body surface. So different things. And during the mapping CAT scan, we use like markers on the skin. We use like a laser for a laser light. So when we align the patient each time, we know that this position is the correct position.
Thank you.
And then I did also have a question as well.
Yeah.
My question is, you mentioned that if the tumor is present, what do they do if the tumor's already been removed?
Yeah, sometimes.
The location. How do they pinpoint the location once the tumor's been removed?
Yeah, so that's a great question. So by using different We use a CT scan, which is the mapping CAT scan. We bring in the PET scan on the MRI from the patient. We fuse them together. And then the surgeons, when they do the surgery, most of the time they place clips. So we can see these clips under the CAT scan, so we know where the tumor is. So it's like a combination of image-guided radiotherapy and also the skin. We look at the skin anatomy spatially, and we use the laser alignment as well. So it's a combination of different things to make sure that we pinpoint the radiation to the right spot.
Okay.
Yeah. And before each treatment, we do the cone beam CT scan, which is a CT scan that takes maybe about a minute or two. We look at this and making sure that those are aligning together with the treatment plan. And so then we know exactly where we're going to treat.
Okay.
Yeah, it's all great questions. Okay, so I'm going to touch base on the side effects that can happen from the radiation. And this is probably the question every patient wants to answer this. The most important thing to remember is the side effects depend almost entirely on where we are treating, not simply on the fact that we are receiving radiation. So for example, radiation to the breast causes different side effects than radiation to the brain. And radiation to the prostate is different from radiation to the head and neck. There is no single list of side effects for all radiation treatments, but I summarize some of them here, such as fatigue and tiredness. And I usually tell the patients that they might need, towards the end of radiation, more like a nap during the day, but things should get better after finishing the radiation, especially after 2 weeks to 3 weeks. And skin irritation, temporary hair loss at the area of treated, but sometimes can be permanent according to the targeted area, but most of the time this hair can grow back but can take some time. Difficulty in swallowing, dry mouth, loose stool, urinary symptoms, especially for the patients with the prostate or GI or rectal cancer and so forth. They might have urinary symptoms. And these side effects usually develop gradually. They often improve after finishing radiation, and many can be prevented or managed. So that's why while you're on treatment, we need to see you once a week. But of course, we encourage the patient to reach out to us if they have any symptoms or any concerns, so we can intervene earlier. Our goal is not only to treat the cancer, but also to help patients stay as comfortable as possible throughout the treatment. Will radiation hurt? Usually no, radiation itself does not hurt, but as I mentioned earlier, is the side effects coming from the radiation. So being proactive and using nowadays, like we're doing at our end, is being more precise with radiation, but also taking the medications, the creams that can help mitigate the side effects for sure. In terms of, some patients would say, would I be able to continue my normal life? So usually you can continue your work, walking, exercising, cooking, traveling short distances, seeing family and friends. So the answer typically depends on the type of treatment and how you're feeling. I always encourage patients to stay active as much as they can, but as much as they are comfortably can. Even light exercise activity can improve fatigue and overall being and sometimes the overall outcomes. So why do I need more than one treatment? Why not only treatment and that's it? So the total radiation dose is often divided into smaller treatments. This gives healthy cells time to recover between treatments, and the number of treatments depend on the type and location of cancer, the goal of treatment, the total radiation dose, the patient's overall health, and some treatments require only 1 to 5 sessions. Others may take several weeks, about 6 weeks or 7 weeks for like head and neck cancer. For breast, sometimes we do five treatments. For the prostate, we do between 5 and sometimes 20. It depends on the clinical scenario, and not all patients are the same. So ask your physician why you're doing this, and there are different differences I'm gonna go over in a second. So your schedule is designed specifically for you. And then at some point, if you cannot attend an appointment, call your treatment team. Do not assume that this MS treatment means the treatment will not work. Sometimes we encourage you to continue the radiation as scheduled, but sometimes we might need to do some calculation to account for break or something. Some of the common myths are like my hair will fall out. It's only the hair that get it treated at the area of it treated may be affected. And then my whole body will be radiated. Not really. So radiation is targeted only to the area of where we're going to treat. There might be scatter radiation somewhere else, but the higher the dose is in the targeted area. And the radiation would burn everyone on the skin. So most patients experience mild skin changes. Severe skin reactions can happen, but they are much less common, especially today, because treatment is trying to make it more precise than it used to be. So before 20 years ago, you might hear stories like maybe more horrible stories about the side effects on the skin. But now with the advanced machines, the multidisciplinary approach with caring of different kind of people here, physicians, nurses, therapists, and all the crew that can mitigate the side effects such as the skin reaction. And as I mentioned earlier, you can be around your grandchildren. You don't radiate radiation. So once you're done with radiation, the external beam, the radiation is not in your body anymore. So you're safe to be around your family, but with the exception of some sort of brachytherapy, certain brachytherapy, and some nuclear medications, like the iodine, for instance.
So, question.
Yeah.
Back on your myths, the guys in my group, my cancer prostate group, kind of reiterate to me that radiation is the gift that keeps on giving. And and that's when I talk about side effects that happened several years ago. But the question I have right now that I don't quite understand, and my doctor's not really giving me a good answer to, is I'm coming up on 8 years post radiation therapy for prostate cancer. And my urologist is looking for my PSA to meet that nadir spot, a low spot. Maybe 4 or 5 years ago, my PSA kept coming down, and I asked my doctor about, is it taking this long for the radiation to kill the cancer? And his response was that I had a slow growing cancer and that it would just take time for it to die. Well, now that I'm up to 8 years, I'll be doing another check this October, but even these last few years, my PSA number keeps dropping. And I asked my doctor, does that mean I still have cancer or what? Because I don't understand why it keeps dropping and we're not getting that bottom line yet. And he didn't really have a good answer for that. So is the radiation, does it take up to 5 years, or is it when you have the therapy, you're done with radiation? I don't understand the time between post-treatment and then the declining PSA over the years. if you have any sort of perspective on that.
Yeah, that's actually a great question. Is a common question that the patients ask about. So there are different kind of cancer cells in the body, and in their how they react, how they grow. So the faster the tumor grows, the faster it get killed by radiation. The slower the tumor grows, the slower it gets dead by the radiation. That's because of the biology of cancer cell death. Going back more on the cancer cell biology, cellular death, is that we have two ways to kill the bad cells, the cancer cells, with radiation. There are chances that the radiation is going to travel and hit directly the DNA, which is about 1/3 of the time, and kill the cell, and that will destroy it afterwards. And then the other 2/3 of the time, it goes to the cell, has about 2/3 of the cell is water, and it will oxidize the water, and that when it's oxidized, it goes and kill the DNA, and that takes longer process. And then the DNA is broken, but the cell, when does it die? It dies when it starts to replicate again. And that time, when it starts to replicate and it gets bigger and duplication of the DNA, the cell finds out about the DNA, it's broken. And then it decides to go back to death. And this, sometimes some cells, they divide within 2 to 3 days. Others, they take about 30 days, and others, they take longer. So when they figure out that the DNA is damaged, it might take some time to kind of have a response of cellular death. So that's how the radiation is different kind when we go with the surgery and take it out, and that's it. But with radiation, it's a process of cellular death when it needs some time to happen. And each site responds to radiation differently, and each tumor responds differently. Going back to the prostate, so the prostate has the cancer and the good cells. The good cells, they also send out PSA, but the process of cellular death of the prostate takes some time. So the PSA might start to go down slowly, but it might go into the nadir where it just stopped there. But that's how we follow up the prostate. I'm actually not I treat more of a head and neck and central nervous system cancer cells, but that's typically how we look at the PSA and the prostate. But each patient is different than others. I would suggest that if you're having some concern or something, that we are happy to help you with that. But typically, this is what happens with the cellular death of the level of the radiation. Does that help at some point?
It
Yeah.
does. I don't look a gift horse in the mouth, if you will. I'm happy it goes down versus going up, but it just kind of boggles my mind that it's going down all these years past my post-treatment. That's what, and the thoughts of cancer still floating around on me still doesn't sit well with me, and I try not to worry about it. But again, it just boggles my mind a little bit that it takes so long.
Yeah. It's yeah, I hear you, I feel you. It's just something when you see that, oh, maybe the PSA is this a number, then we'll be yeah, here's, of course, it's your body and it's something inside you feel worried about. But as long as the PSA is going down, this is a good sign. Yeah.
Thank you.
For sure. Yeah.
And then I did have a question as well. You mentioned about specifically pinpointing cells, the cancer cells, what kind of works on all the cells. will my immunity go down during the radiation treatments?
Yeah, that's a great question. So, how we think about the immunity is that the bone marrow is the main place where where the immune system is gonna come from, like the white blood cells mainly. So it literally depends on the volume of the radiation and the area of where we're gonna treat. There are multiple trials that showed that the chances of having low white blood cells after radiation, certain areas, is unlikely to happen. But if we're treating a big volume of the bone, there's a higher chance that we're gonna have low white blood cells that will affect your immune system. But typically those are temporary and things should get better after finishing the radiation. So it's difficult to say yes or no on this question, but it depends on multiple factors. That's why we do the pinpointed radiation. The smaller the volume of the radiation, the lower the chances of having immune issues. And it depends typically on the site of the radiation. If it's like some patients will get a total body radiation or for some sort of bone marrow transplant or something, those are typically, they will have low blood counts. Some patients will treat their whole brain and spine. So those are typically a higher chance of having lower white blood cells or immune cells. But if we're treating, for instance, one single point in the brain, the chances of having decrease of white blood cells or immunity will be extremely low.
Is that something y'all monitor during radiation through blood work?
Typically, we monitor if the radiation volume is bigger, but if it's case by case. If the patient is more prone to have white blood cells drop, if the patient is getting chemotherapy. So it's multifactorial. Usually, typically, if we do radiation that it's pinpointed to the area that it's not bigger, we don't follow the white blood cells or the blood count. But at the end, it depends on each patient, like history and their comorbidities and other factors.
Okay.
Those are all great questions. We talked about the radiation team. We have a bigger team with the radiation oncologists, physicists, dosimetrists, radiation therapists, nurses, dietitians, speech therapists, social workers, and the patient navigator. So it's like a multidisciplinary approach for each patient to make sure that the treatment is safe and correct. And then, as you all proactive, I advise the patients to be proactive and ask questions when they go to the clinic. Each case is different than other cases, so I would suggest you like to go and stick with the medical references, good references, and your physician and the treating team. So ask question, bring someone with you to your appointment that will help you. Sometimes overwhelming information. So that's a great point to go with. Tell us about your symptoms as early as possible. Take care of nutrition, stay hydrated, walk a little as much as you can during the day, just to make sure you're still active. And accept help when it is offered. Some patients are stubborn. I like the stubbornness to fight this, but also reach out for help to go through this. Remember that you're not facing the cancer alone. You have the whole crew around you that can help you through that. So don't wait until symptoms become severe. Continue monitoring yourself. Make sure to ask questions. don't underestimate anything. You're not bothering the physician. It's the other way around. Like you just keep asking, because this is your body at the end. So you make sure that you're in a safe spot. And during treatment, eat enough calories and protein, because you need calories to fight the cancer and stay strong. Make sure you have enough fluids per day. Remain active as much as you can. Rest when your body needs it. And use only like for some skin products, they don't go along with the radiation. So just follow the recommendations as well from your treating physician. Tell us about every medication, vitamin, herb, and supplements you're taking. Do not start a restrictive diet without discussing it with your team. And of course, avoid smoking and tobacco, and ask for help with nutrition, transportation for patients living farther, finances and anxiety or caregiving. We have the social worker here, and I think at different spots as well. And after finishing the radiation, going back, I guess like prostate cancer, we do follow-up patients different than head and neck cancer and different than the breast cancer. But typically, finishing radiation is the first milestone can happen after the radiation. But then the recovery takes some time. Most of the time, things might get worse after the 2 weeks of finishing radiation, but things should get better day by day after that. Stick with the follow-up care with your doctor, explain follow-up visits, and continue reporting new or persistent symptoms, and learning the biology of cellular killing and why doing each test, blood test or scan, is essential to kind of feel comfortable about what you're going to do. And then the long-term monitoring is very important as well. And those are the questions that I think patients, they might need to ask their physicians or the treating team. It's like, why you're doing this, the goal of treatment radiation. It's like, oh, my prostate is the plan is for cure, to get rid of radiation. And how my treatments will, how many treatments? Some patients will get 5 treatments, 20 treatments. Ask why. What benefits can I reasonably expect? And what side effects are most likely for the area of being treated? And sometimes you put up like Google, and nowadays ChatGPT, and it can give you a lot of side effects. But radiation, it depends on the site where we're treating. What can we do to prevent or manage those side effects? Some pills, creams, or things that you do or you should not do that can help mitigate the side effects. And the high alert side effects, like what are the most important side effects that can happen that I have to call you immediately or go to the emergency department. So knowing all these information is a lot of things. It's like overwhelming for sure, but that can put you in a safe place. And all of these questions will lead to like understanding your body response is very essential. This is part of how we perceive the information and how we react. So you hear the news and then you start to be, oh, what's going to happen next? Will be like, a lot of questions are going to come into back of your mind. And your brain switches into survival mode. And then your brain first job is not to make you happy. It's just to make you stay alive. So your body response will be, oh, your heart rate is going to go faster, you're breathing faster, your muscles are tight, trouble sleeping, loss of appetite, and difficulty concentration. So your mind fills in the unknown, and the reaction will follow like, oh, I want to avoid the appointments. I don't want to go. I don't want to do this anymore. I will just maybe give up. But however, the good news is the same brain that creates fear for you can also learn safety. When your body begins to relax, your thinking becomes cleaner. and clearer. Your decisions become better and confident, or with your confidence, and your confidence will grow better. So you need to pause and think, breathe. There's a way like to take one slow breathe and exhale a little longer, then inhale, exhale, repeat 3 to 4, 5 times, and then check the facts. What do I know for certain? What questions should I ask my cancer care team? Am I predicting the future or looking at today's facts? So stay connected with your family, with your care team, cancer support community, and no one should be doing this by themselves, but like alone. And focus on today's step and take one step at a time, for sure. And
Dr. Dibs,
remember,
we have a question in the chat. Winnie asks, why does radiation help relieve pain?
when or where?
The question.
Why?
Why?
Yeah, because I had my T9, I had my leg treated for the initial metastasis of the breast cancer to the bone in my leg. And then they found a spot at the T9 and I had regular radiation there. But now I've been having so much back pain, lower back pain, and I start radiation tomorrow, as a matter of fact, but they're going to do the cyber knife. And he said it should help relieve the pain. And I guess I didn't think about it then, but as the week as now, I've had the CAT scan and everything to get the preparation. But I guess I'm wondering, why does the radiation help the pain, and will it stop the growth of what's in the L4 now?
Yeah, so that's a great question. So pain is perceived in the body because of something going wrong, like the tumor is growing and it's pushing, like in your situation, or it's like in the bone situation, it's going and pushing the cortex, which is our outer part of the bone, and some inflammation there that will lead to pain. And we call that a biologic pain. And that will improve if we start to shrink the tumor. So yes, radiation is gonna go travel through the skin, pinpointed to that area, kill the bad cells, and then pain might get worse initially. And there's about 15% of the time, patients might have increase in pain after finishing the radiation or at the time of radiation. That's because of your body response to this and for the inflammation. And then the tumor, like your white blood cells, will come and eat the bad cells that are dying, and then will shrink down. That will lead to settle down in the inflammation, and the pain will get better day by day for sure.
Okay. Thank you.
Yeah.
And we have another question in the room.
Yeah, doctor, side effects, radiation burn to the bladder. Any suggestions on that for treatment?
Yeah, so sometimes we treat close to the bladder. Like for instance, we treat the rectum, we treat the prostate, we treat the uterus, part of the uterus, the cervix. That will lead to inflammation in the bladder. It depends on multiple. There are some kind of medications that can decrease the inflammation in the bladder to decrease the chances of having burning during urination, frequency. So those, or like all there's like different kind of medication that can be used, and it depends on the cause. So some patients will get radiation, but that may be there's an infection in the bladder, so we need to treat the infection so we can have a better outcome. So how we do this, we do an analysis for the urine, and we look at the cause of the burning. If the burning is related to an infection, we give you an antibiotic. If it's radiation induced, there are different kind of medication that can be used to mitigate this kind of side effects for sure. So ask your physician. Yeah, go ahead.
Yeah, I have. I mean, of course. Yeah, but 2 years ago, anal cancer, radiation, but the bladder was what was left. bleeding and infection, constant antibiotic for 2 years. And one doctor finally recommended hyperbaric treatment.
Right.
And I did do that. And it took about a month after, but it absolutely gave me relief now for about 9 months of
Mhm.
no antibiotic. But I just started back into a little bit of bleeding, an infection again, and an antibiotic. And I just didn't know if you had some other alternatives, or of course I go back to hyperbaric treatment, but yeah, it's a lot.
Yeah, I hear you. I mean, like, it's hard to give like a medical advice for not knowing the details of the case, but for sure, one of the answers for like a treatment for uh, radiation-induced bladder injury is or inflammation is the hyperbaric oxygen. It can be repeated in certain situations. But typically, yes, so those are like if there's anything like repeated infection, I would go also follow with urologist also. Maybe there's something like a structural issue that they can fix. But yeah, it's kind of hard to give medical advice without knowing all the blood tests, the images, and so forth. But yeah, there definitely there are other options for sure.
Thank you.
You're welcome.
I have a similar question. Thank you for bringing that up.
Oh, yeah, fun.
During my radiation, I had some problems with my colon. And you probably can't answer specifically, but I had issues. I went to my colon rectal doctor and he looked and he said that I had what he called like a sunburn in my colon from the radiation. Colon proctitis or something, colonitis or something like that. I
Correct.
thought the colon was one of the organs that basically repaired itself. And, you know, I had my colonoscopy, and when he did the procedure, he accidentally poked that spot and it started bleeding all. And I don't know what he did, but after that situation, I stopped having bleeding during bowel movements. So I'm grateful. But I'm coming up on another colonoscopy in October, and I'm kind of wondering what's going to happen. But again, I thought the colon was one of those organs that repaired itself. And why would it linger so long and not repair itself from the radiation? If you have any ideas.
Yeah, unfortunately, sometimes with radiation, we might have long-term side effects. So when we talk to the patients, we tell them about something called like a short-term side effects, and there's a long-term side effect. Like any procedure, it can have some sort of long-term side effects that can happen to the surrounding area, such as fibrosis, scarring, even like injury to the colon. And then colon, they have the ability to regenerate, but also it depends on how much dose of radiation received. Some patients are more sensitive than others. So I would give like an example, like sometimes some patients would say, oh, my friend had the same radiation, but never had, like didn't have any symptoms, but I did like this same radiation and had a lot of symptoms. And then sometimes like I would tell them like, if two of us, we went to the beach and then I stayed there for a few hours and you stay for the same hours, I get burned, you don't get burned, or even like we use the same sunscreen. So the tissue sensitivity and reaction to radiation, it's different from patient to patient. But without when it happened, maybe like there are some sort of medications, procedures that can be done for like proctitis or colitis that can help. But unfortunately, there's a rare situation where things can last longer. But yeah, I can't give like a final decision on this situation, given that I don't have the details of the colonoscopy and the radiation treatment plan. Because we look at the plan itself, like we see at where was the radiation? Is it scattered from here, or like where was that pinpointed? That can give us like a big picture. But unfortunately, yes. So some patients might have some sort of side effects to the bowel that can lead to even like a perforation, rare, but rarely, it's extremely rare, but can happen. Bleeding in the colon uh, and bowel obstruction.
If I'm hearing, I'm sorry to interrupt, but if I'm hearing you, it's all dependent on how much radiation really hit the colon, to whether it will repair itself or not. I think that's what I'm hearing from
Yeah.
your explanation. So,
Right, correct.
yeah, okay, thank you.
You're welcome.
Ooh, one more question.
Yeah.
You know, you hear about different cancers. I've been through 3 different cancers multiple times. And sometimes they'll do radiation first and then they do chemo. Sometimes they do chemo and then radiation. You know, I mean, sometimes they just do radiation. I know it depends on the cancer and all that, but why would you reverse it? Like, was that just years ago they did it differently and now they kind of updated?
Yeah, that's a great question. So some cancers, like they grow, for instance, somewhere in the body, but they have the tendency to travel somewhere else. So some tumors are big enough, like they're bigger, so we need to downsize them. So we can, when we give the radiation, or they do surgery and then radiation, so we have a smaller volume of radiation needed to be treated. The other reason why we do also the chemotherapy first is to attack areas that we can't attack with radiation. There are some areas in the body that might harbor these small, tiny cells that we don't see in the images that the chemotherapy will be taking care of. So we control the cancer everywhere else, shrink the tumor meanwhile, take it out and do surgery or do radiation or do radiation alone. So each site can be treated differently. And even like not only each site, like some breast cancers, for instance, the biology that we do like biological tests, like hormonal receptors and some genetic testing and so forth. We do biopsy, and according to the stage and the behavior of the tumor, we can do chemotherapy first and then surgery and then radiation, and or we can change the timing of each. So others, such as rectal cancer, now there are multiple options. It depends on the stage and the behavior of the tumor. We can do chemotherapy first, and then chemo and radiation, and then surgery. And sometimes, if it's gone, we can discuss organ preservation, which is when we don't do surgery, we just follow up on the images and the scopes and biopsies if the tumor is gone with chemo and radiation. So typically it's to shrink the tumor itself, but also to take care of the cancer cells that we don't see anywhere else in the body. Yep, that's a great question too. Any other questions?
I have a quick question. We had a caregiver support group on Monday, and one of our caregivers said that her husband had received radiation for his cancer as part of his treatment, and now he can never have radiation again. She wasn't able to join us today, so I'm asking that question for her.
That's a great question too.
Yeah.
So, the question is yes and no. So usually, we do radiation, and that area that have seen radiation will have the memory of the radiation. So we try to avoid re-irradiating the area. But if sometimes what we do is we wait 6 months for that normal tissue to heal and regenerate, so we can do radiation, another round of radiation. We can do another round of radiation to the spine. We can do another round of radiation in the breast, the brain, the head and neck
What about
area.
the
Different
prostate?
type of. What's that?
What about the prostate?
So the prostate, well, at the end, it depends on multiple things, is the symptoms. The prostate also, like, we can do re-irradiation, and I think multiple physicians done that before, and then in the literature, it's well known. But we look at multiple factors. So if the patient is having a lot of symptoms, such as urinary symptoms, rectal symptoms, bowel symptoms, and you don't want to add injury to an injury. So because it's like a balance between benefits and risks. If the risks outweigh the benefit, we avoid doing radiation another round. But if there's a benefit that is safe for the patient, and we don't have chances of having higher chances of side effects, we can repeat the radiation for sure, any site in the body. Usually we give about 6 months from the previous radiation. But sometimes we can consider radiation in certain clinical scenarios when it's safe enough and when it's reasonable, of course, too.
Thank you.
Yeah, you are. Yeah, I know it's about 1 p.m. I don't want to, if you have any questions or something I can help with. I've been here in Ohio for about almost 8 years. I love it here. I would love to help people of Ohio and from wherever too. I'd love to support you guys, and then if there's anything I can help with, I'm happy to guide you. Every patient is different than each one of us, so each case is unique. I would for sure discuss the case with your primary physician, ask for second opinion. That's not something the physician or anyone will take it personally. Read from different resources. I put in something here like NCI, ASTRO, which is the RT Answers, American Cancer Society, also the James Patient Education and Support Services. Reach out to the cancer support community of Central Ohio. If they'll help you, guide you to go to where to go, because each case is different. And I don't know if you've seen this ring the bell thing in radiation. That's one of my greatest privileges in my career, watching patients ring the bell after completing radiation. That moment represents far more than finishing radiation. It represents courage, perseverance, hope, and every patient's journey is different. Really proud of the patients who go through this. This is not an easy treatment for sure, but we're here to help. Some of the treatments are long, others are straightforward. Some of them are very challenging, but there are different organizations that can help you, hospitals. So ask about education, support, connection, and yeah, we're happy to help, and we're here for you guys. And then I really thank you.
Thanks for your time.
Yeah.
Thank,
Yeah. Thank you so much for allowing me to be here. It's very nice to, after learning and to pay back for the community, for the patients, for whatever it takes. And it always takes a village to go through such treatments, you know.
Yes, sir.
Thank you.
Thanks again.
Thanks for.
Yeah, you're welcome.
Bye, everybody.
Bye.
Bye-bye.
I'm proud